Hello everybody, my name is Fernando Duarte and I'm from Oporto, Portugal, and my topic for today is the treatment of maxillary inflammatory odontogenic cyst with laser therapy, a case report that I done with my colleague Dr. Karina Ramos from Oporto, Portugal also. The anamnesis of this patient, a 55-year-old female patient, Caucasian, that attend to our clinic to evaluate the dental cyst in the second quadrant, diagnosed during the evaluation to place dental implants in the upper jaw in the other clinic that works with us. The patient has been generally healthy with no serious illness. There was no allergies or use of medications. On extraoral clinical examination, an aspect of normality was observed. From the dental observation, on intraoral clinical examination, there was nothing relevant to report, and the patient has a good oral health condition. From the hard tissue status, we can see that there are a lot of teeth missing. 14, 15, 18, 22, 23, 24, 25, 26, 27, 28, 36, 37, 44, 46 and 47. There was some teeth with treatment, endodontic treatment, the 12, 30, 33, 34 and 35, and with some composite restorations in the 13, 16 and 45. From the soft tissue status, the gingival tissue was healthy and the plaque control and oral gene was also good. TMJ evaluation showed no evidence of pathology with normal jaw movement, and in terms of occlusion we are talking about an angle class 1 situation. In terms of diagnosis, the odontogenic cysts occur in the oral and maxillofacial region. Most jaw cysts are lined by epithelium derived from odontogenic epithelium associated with tooth development. The odontogenic cyst can be classified as development type or inflammatory type. The development odontogenic cysts encompass keraticized, dentisuous cyst, lateral periodontal cyst, cysto-odontogenic cyst, and eruption and gingival cysts. The inflammatory types include radicular, residual, and periodontal cysts. Although some odontogenic cysts are relatively common and should pose no diagnosed challenge, they are often misdiagnosed due to the many clinical and radiological similarities. As some of these cysts are aggressive and may recur, all the surgically removed tissue should be examined histopathologically. Early and accurate diagnosis will often ensure appropriate treatment and follow-up. The cysts are epithelial odontogenic inflammatory lesions characterized by a pattern of slow, expansive and non-infiltrated growth. This is clear evidence of benign biological nature of these lesions, which can reach considerable size if not diagnosed in time and treated appropriately. A correct diagnosis is essential for planning the treatment of conditions that compromise the maxillomandibular complex. Given that the number of cystic lesions of the jaws share similar clinical and radiographic features, the diagnosis of odontogenic cysts usually requires detailed analysis of the clinical, radiological, and histopathological findings. And here it is our patient. As you can see, she was looking for a change in aesthetics, mainly in the upper jaw. And the teeth condition, of course, there was a lack of some teeth, the biting and the biting situation, it was also a concern, and the patient wants to change everything, placing implants in the edentulous areas. As you can see in the CT scan, there was a massive lesion involving the teeth 2.1 and 2.2, but also some degree of bone expansion that could not allow the placement of dental implants in the same stage. In other perspective, we can see that the cyst is already in the maxilla for a long time because we have some degree of bone expansion. Now, as we go detailed in our radiological cuts, there was some degree of communication already between the nasal cavity and our dental cyst. The maxillary sinus appears not to have communication with the cyst. Now, when we go to the topographic cuts, you will see that the teeth that are involved are also with close relation with the cyst. And in the 3D reconstruction perspective, we can see the size of the cyst, the anatomic position, and also the anatomic structures involved. Our treatment plan was like all odontogenic cysts, with the inception of inflammatory periapical cysts and lateral radicular cysts should be treated with a surgical intervention. The periapical cyst lesions are usually treated by conservative endodontic treatment, periapical curettage, or surgical treatment like enucleation, marsupialization, or decompression. In lateral radicular and inflammatory periapical cysts, surgery is indicated only if the lesion do not regress after removal of odontogenic infection intracanal the affected tooth. In case of residual cyst, surgery is the only option. Our treatment plan was local anesthetic, a combination between lidocaine and epinephrine, and using the laser. For that we use the light Walker laser with some settings. The first setting was for the soft tissue. We done the incision with the erbium YAG using the handpiece H14 with 150 millijoules, 20 Hz, 3 watts, and combination of 4 for water, 2 for the air in the LP mode. And for the hard tissue, for the osteotomy, we use also the erbium YAG laser with the same handpiece, but from energy a little bit more, 170 millijoules, 15 Hz of frequency, 2.55 watts of power, and the combination was 6 of water, 4 of air in the SP mode. Now, as the cystic cavity was considerable, we tried to do some degree of preparation, and for that we used a combination of 4 steps. The first step was for the granulation, the second one for disinfection, the third for dedepithelialization, and the fourth one for cloth stabilization. And we changed from the erbium to neodymium. The granulation, we used the erbium with the handpiece H14. For disinfection, we used the neodymium with the handpiece E300. For the dedepithelialization, again, the erbium with the same handpiece. And for the cloth stabilization, the neodymium. We'll try to get the best from each laser. In the same surgical time, our goal was to do the bone reconstruction, and for that we use a biomaterial from Ceresorb M, that is from Kurzan, a German company, in granules, combined with fibrin to build what we call the sticky bone, and a resorbable membrane from the same company was also used. The use of autologous leukoplakia fibrin in the graft procedures allows to enjoy its characteristics, namely the modeling of the inflammatory response, immune response and tissue repair, tissue reorganization and angiogenesis. The association of PRF with mineral biomaterials, the IPRF, facilitates handling, application and allows immediate adhesion to the receiving bed. The suture was also performed using non-resorbable threads. Finally, we done photobiomodulation And for that we use the neodymium YAG laser in the Genova end piece with the MCP mode, 10 Hertz and 0.5 watts. One spot from buccal side, one from palatine side, 60 seconds per spot for pain reduction and to achieve fast healing. The photobiomodulation was repeated twice every second day. And here it is. We have our clinical images and also our settings. The settings for the soft tissue with the erbium YAG, as you can see there, to do the incision, and also the settings for the osteotomy using the same erbium YAG as I told you before. And as you can see in the pictures, we managed to remove the cyst in completely integrity and all the capsule of the cyst. After that, we start to prepare the cystic cavity, and as I described, we done it in 4 steps. The step 1, degranulation, the step 2, disinfection, the step 3, deepitalization, and the step 4, clot stabilization. It's very important to try to keep the maximum of bone that you are able of, because it's very important for the reconstruction, and as you can see here, we try to do it. Now, bone reconstruction, the sticky bone. As you know, for the fibrin protocol, we can use the fibrin in 3 different ways. We mixed with biomaterial, and this is a sticky bone. We can use it as a membrane, or we can use it as a glue. And in this clinical case, we tried in the 3 different ways. On top of that, we put a resorbable membrane. And finally, the photobiomodulation. We use the Genova end piece with the different settings and apply after the surgery. And now let's see the video of the clinical case. We start by the incision with the erbium YAG and piece H14, very easy to handle, very precise. We use 150 millijoules energy, 20 Hertz of frequency, 3 watts of power, and also a combination for water-air 422 in the LP mode. Detachment of the mucosa after raising the flap and start to work in the hard tissue. For that we change a little bit the settings, and for the osteotomy we are using also the erbium YAG with the same handpiece H14, but the settings are different with more energy, 170 millijoules, the frequency 15 and the power 255, what allow us to remove the cyst completely. Enucleation of the cyst is important to work on the bone edges to be smooth, because we want to remove the cyst and also the bone reconstruction in the same surgical time. Now, as you can see here, we are applying the protocol for the cyst cavity preparation, including the granulation, disinfection, and deepitalization, and also clot stabilization, as you can see here, with the neodymium YAG, the final part of this protocol. Now, it's important also the bone reconstruction. We use the same surgical time. For that we apply the fibrin protocol mixed with the biomaterial, creating the sticky bone, as you can see here. The fibrin protocol may be using biomaterial with fibrin, also fibrin membranes, and completing with the fibrin glue. And here they are, the fibrin membranes, and the reconstruction will be completed with a resorbable membrane on top of it to protect the bone graft. And here it is, stitching with the silk, and finally In the same procedure, we will do photobiomodulation. For that, we use the neodymium Genova handpiece in MSP mode in a frequency of 10 Hz and in a power of 0.5 watts. We will do one spot from the buccal side, one from the palatine side, Now, let's see the final result. From the OPG post-op, you can see that the bone reconstruction was well done with very bone, and the post-op CT scan also show us that we managed to remove all the cysts and also the good to achieve a good bone reconstruction. The biomaterial is very compact and fulfilling all the cavity. After 4 months, our colleague will be able to place the dental implant. And here, the cuts, you see the bone density occupying all the space. 3D images from the bone reconstruction. And our follow-up. The patient had a post-operative period with no pain and local edema. Antibiotic was an anti-inflammatory analgesic was prescribed, and after 6 months of follow-up period, the patient is pain-free and the lesion has no signs of recurrence. As conclusion, the surgical treatment of maxillary inflammatory odontogenic cyst with laser therapy is safe, predictable, and with excellent results, allowing to place dental implants in the near future. The choice of settings is of crucial importance in obtaining the desired results. Some of the scientific papers that we use to prepare this presentation. Finally, our contacts if you have any doubts, if you want to do some comments on our opinions. Thank you very much. Appreciate it. Hello everybody, my name is Fernando Duarte and I'm from Oporto, Portugal, and the topic for today is surgical treatment of oral leukoplakia using YAG Laser is a case report that I done together with Dr. Karina Ramos, also from Oporto, Portugal. This patient, a 63-year-old male patient, Caucasian, attended to our clinic to the Department of Oral Maxillofacial Surgery to evaluate a white lesion in the left jugal mucosa. The patient has been generally healthy with no serious illness, and there was no allergies or use of medications. On extraoral clinical examination, an aspect of normality was observed. From the dental evaluation, on intraoral clinical examination was detected an extensive white lesion, more or less 2 cm, irregular, with well-defined edges at the level of the buccal mucosa of the third quadrant, and with intercalated erythroplastic zones. It is not related to the occasional trauma, nor does it stand out easily. Lesion with evaluation of about 1 year, but without symptomatology. The hard tissue status revealed that there were a lot of teeth missing, 1.1, 1.2, 1.4, 1.5, 2.1, 2.2, 2.4, 2.5, 3.3, 3.6, 3.7, 4.6 and 4.7. The third molars were not present and the tooth 4.5 was in the impacted position. The teeth 1.7 and 2.6 had received endodontic treatment, and the teeth 13, 16, 23, 27, 34, 35 and 37 had amalgam restorations. In the soft tissue evaluation there was no complications. The gingival tissue was very healthy and the plaque control and the oral hygiene was regular. The TMJ with an palpation of both TMJ showed no evidence of pathology, and the occlusion was an angle class 1. Leukoplakia is a clinical term indicating a white patch or plaque of oral mucosa that cannot be rubbed off or cannot be characterized clinically as any other disease. This excludes lesions such as lichen planus, candidias, leukoedema, white sponge nevus, and obviously clinical frictional keratosis. These leukoplakias may have similar clinical appearance but have a considerable degree of microscopic heterogeneity because leukoplakias may range microscopically from benign hyperkeratosis to invasive squamous cell carcinomas. A biopsy is mandatory to establish a definitive diagnosis. Many cases of leukoplakia are etiologically related to the use of tobacco in smoked or smokeless forms, and many regress after continuing of tobacco use. Other factors such as alcohol abuse, trauma, or Candida albicans infection may have a role in the etiology of leukoplakia. Nutritional factors have also been cited as important, especially related to iron deficiency, anemia, and development of sideropenic dysphagia. This is called the Plummer-Vinson or Patterson-Kelly syndrome. Predominant sites of occurrence have changed through the years. At one time, the tongue was the most common site for leukoplakia, but this area has given way to the mandibular mucosa and to the buccal mucosa. Like in this case, it was the mandibular mucosa. The palate, maxillary ridge, and lower lip are somewhat less often involved, and the floor of the mouth and retromolar sides are less often involved also. In this case, we perform the incisional biopsy and the evaluation of pathological anatomy and reveal histology of the lesion and reveal a mucosa covered by stratified squamous epithelium with marked acanthosis and ortho and parakeratotic hyperkeratosis, focal spongiosis, vascular degeneration of basal keratinocytes, and occasionally basal keratinocytes were identified. In the chorion, a band of lymphocytic inflammatory infiltrate was observed, which focally permeates the lining epithelium. Focal lesions of low-grade dysphagia were also identified. No signs of malignancy were observed. Based on this report indicating of leukoplakia, it was decided to carry out a surgical treatment of the lesion using YAG Laser. Here it is the clinical aspect, initial clinical aspect of the lesion. As you can see, the lesion range in a considerable area in the third molar, near the molar, but also expanding a lot from the mucosa. Our treatment plan was to use the YAG Laser because it vaporized the lesion through the photothermal effect on water molecules. It completely absorbs into superficial tissue layer and such preventing damage to the surrounding structures. This is very important when removing deep layers around nerves and vessels. The control of bleeding, we know that is higher with the neodymium YAG, but erbium YAG is safer. We use also a long pulse LP mode because high risk of thermal damage to the hard tissue, but allows us a deeper penetration for the increasing degree of dysplasia. That was very important in this case. Local anesthetic was infiltrated in the soft tissue surrounding the lesion, lidocaine and epinephrine, and the erbium YAG was used, as I said before, with a handpiece R16, 3.6 joules per square centimeter in energy, 10 Hz, and 13.8 watts in the LP mode. And here we can see the video of the first session of the treatment. As I told you before, we are using the erbium YAG handpiece R16 with 3.6 joules, 10 Hz from frequency, and also 13.8 power in LP mode. The objective is to vaporize the superficial, the intermediate and also the deep layer of the Leukoplakia. The patient was very collaborative with the treatment, no problem in terms of moving the head for the best angle for us to apply the laser. And also we can see an immediate transformation in the tissue. It's very important to be very meticulous when you apply the laser on this kind of lesions. Reflecting well the jugal mucosa, and because we are working on the posterior area of the mandible, the visualization of the soft tissue and the lesion is very important. Okay, and after first laser session we reached to this result. The result was not completely positive because we have some spots of lesion that we can clinically identify, and second laser session, this one with much better results. Of course, when you compare with the initial situation, the first session was already a very good progress, but with the second session we managed to completely remove the follow-up of this case. The patient had a post-operative period with no pain and local edema. Anti-inflammatory analgesic was prescribed, and as I told before, we done a second session after 30 days, the first session. Only in the areas that showed some degree of dysplasia. After a 12 months follow-up, the patient is pain-free and the lesion has no sign of recurrence. As conclusions of this clinical case, the surgical treatment of Leukoplakia using YAG Laser is safe, predictable, and with excellent results in the short, medium and long term. The choice of settings is of crucial importance in obtaining the desired results, and here is the settings that we use for this clinical case. Some of the references used for this work. Of course, thank you very much. I leave our contact if you have any doubts or if you want to make some questions. Thank you.